Hi, I'm Barbara Bauman. I'm one of the AF-CBT trainers, and I'm going to talk to you today about the 4 theories that make up AF-CBT to give you a little understanding about the different techniques and how they come together. AF-CBT is made up of 4 theories that work together to address the entire family system: cognitive therapy, development victimology, social learning, and family systems. I'm going to start with cognitive theory because it's the best known of the 4 and the basis for the model. Cognitive theory suggests the idea that our thought processes control our feelings and influence our behaviors, so that by changing our thoughts, we can then change our feelings and our behaviors. An example I like to think about is if you had 2 different caregivers watching a child have a temper tantrum. What they're thinking about that temper tantrum will influence their behaviors and their feelings. So for example, you might have one parent who watches the kid temper tantrum and personalizes it, thinks, why are they doing this to me? Gets angry, perhaps gets embarrassed, grabs the child roughly and yanks them away, screaming and yelling at them. The consequence is typically a prolonged argument, everyone feeling badly, and a repeat of this behavior in the future. So you could have the same situation with a different adult whose thought might be, this too shall pass. They are annoyed, but they're not highly annoyed. They're uncomfortable, they walk away a few feet, call a friend, talk to another adult, distract themselves for a while. In the meantime, the child resolves their behavior, soothes themselves, and later the parent and child are able to figure out what to do for the next time. The consequence might be a productive conversation between the child and parent, people not feeling badly, and the child being less likely to repeat that behavior. 2 different thoughts result in different behaviors, different feelings, and different consequences. That's the idea behind cognitive theory. We also use social learning theory in the AF-CBT model. Social learning theory suggests the idea that people are influenced by their environment and their behavior, and that they in turn influence their environment and their behavior. So that's why we really stress in AF-CBT working with the whole environment, whether that's the school, a foster family, a biological family, or a sibling group. We're trying to help the child to be different, the environment to be different, and the behaviors to be different. And we feel that by working in all 3 of those, we're able to have them influence each other. One idea of this might be a kid who's really aggressive, and if the parent ignores that behavior, then that behavior might go away. Whereas if the parent attends to that behavior, it might increase it. So that's the environment we're trying to work on, as well as the child with the impact on the behavior. Family systems is a really key part of the AF-CBT model. We're really focused on the family being the unit in which the child operates. So you'll see when you get to know the model better that we're going to spend the first couple phases of the model really building individual skills with the parent and with the child separately. And then we bring them all together for our last phase and really focus on that family system. The idea that by having them together as a family, each person in the family is going to influence the other person. This may include aunts and uncles as well, grandparents, siblings. We're really looking at that whole system and trying to influence behavior within that system, feeling that that's the best bet to get better behavior and a higher functioning family. Lastly, I want to talk a little bit about developmental victimology. While a lot of words, it means, I think, what most of us know who work with children, that children at different ages of development, at different stages of development, behave differently, and that when they experience a trauma at those different ages, it impacts them differently. So a toddler experiencing a trauma is different than a teen experiencing that exact same trauma. That when the trauma happens in development affects the child. So it could affect their brain, it could affect their neurodevelopment, their cognitive functioning and processing, their sensitivity, their stimulation. It could affect lots of different factors, and that's what we want to think about as the clinicians, and what we want to help families think about, especially parents who are trying to help them develop empathy. Often an issue with some of the families we work with, we want to help them understand that this development of the child plays a role in how the child's going to react. I'm Barbara Bauman. I'm one of the AF-CBT trainers and consultants. I'm going to be talking to you today about evidence-based practice and why AF-CBT is an evidence-based practice and what that evidence is. So an evidence-based practice simply means that the intervention has had some research done on it to show that the techniques we're using produce the outcomes that we're looking for. And the research on AF-CBT started in the early 90s and was first published in 1996. The study that was done then was looking at children referred by Child Protective Services for an allegation of child physical abuse. And they were randomized to one of three groups. The AF-CBT model was broken up at that time into the cognitive behavioral components and the family therapy components. And clients could get one of those, or they could get routine care in the community. All clients filled out an intake assessment at the beginning of treatment, and then we followed them up a year later to see what had happened and to see what the outcomes were and if they were as we expected. One of the big outcomes we looked at that time was caregiver recidivism. In other words, did the caregiver have another allegation of child physical abuse during the course of that year? We found a significant difference there. The group that got AF-CBT, either in the CBT group or the family system group, had a recidivism rate of 5 or 6%. The group in the routine community care had a recidivism rate of 33%. So that was significantly different. It made it look like AF-CBT is able to help folks change their behaviors, and that in fact bared out in the records. We then also asked parents and children about their behaviors, and we specifically asked about their reduction in aggressive behavior. We asked caregivers if children were doing more or less aggressive behaviors, and the report was that the aggressive behavior in the children and the adults decreased over the course of that year, more so in the AF-CBT group. The AF-CBT group also had an increase in how cohesive their family was, how much the family felt that they were one unit and they were together on the same page with issues, and a decrease in the family conflict. So one of the main things we're looking for in AF-CBT is to decrease conflict and to change behavior, to have more positive family environment. And this study showed that we were able to do both. The next step was to take this to the community and see what would it look like if we trained clinicians in a community setting to do AF-CBT. And this study took place and was published in 2005 out of a Salt Lake City, Utah clinic. And they trained their clinicians in AF-CBT along with some other evidence-based practices, and had the same process of clients and therapists filling out forms before they began treatment and at the end of treatment. And they found very similar results. They found a reduction in aggressive child and caregiver behavior, and they found an increase in the social competency of the children, reported by both therapists and caregivers. The children seem more able to relate to peers and have more positive relationships, and the children reported that their parents were more nurturing to them following the treatment. So we take from this that there is an evidence base for the different practices that we'll be going through as we learn more about AF-CBT. Hi, I'm Barbara Bauman. I'm one of the trainers and consultants for Alternatives for Families. I'm going to be talking to you about AF-CBT eligibility. You might be wondering who is going to be eligible on your caseload for you to use this model with. I'm going to go through a lot of the criteria today, and then we can answer more in person. AF-CBT is appropriate for children ages 5 through 17 who have a caregiver who will participate in services. And we'll get into some details about who can that caregiver be. Child and caregiver need to be able to adequately participate in the treatment process. So what does that mean? We're looking for folks who can be there, can be present. Usually folks would not be appropriate if they have such a high level of substance abuse that they are not able to be sober and present during the majority of sessions, or folks who have such high psychotic or paranoia symptoms that they're not able to participate appropriately. Otherwise, most caregivers are going to be able to do it, as well as most children, and will adjust for the developmental and cognitive level of the client. So we're going to go over the criteria for the caregiver and the child. And one of the nice things about AF-CBT is that concerns that you or someone else might have with either the caregiver or the child might make them appropriate for AF-CBT. We're just looking for one of these criteria. So for the caregiver, it perhaps is someone who has done something that resulted or could have resulted in injury or harm to the child. Or it could be someone who has likely used some type of excessive or harsh physical discipline with a child, or has family conflicts and or heated arguments, which could include verbal aggression, verbal abuse. We're looking at any one of these criteria could make a caregiver eligible for AF-CBT along with their family. Similarly, it could be that it's not a caregiver concern that brings them to treatment, but a child concern. So the child concerns that would make someone eligible for AF-CBT are if the child has a pattern of oppositional, argumentative, explosive, angry behaviors, any of those type of externalizing issues, or has been verbally or physically aggressive. Now, they could be verbally or physically aggressive with someone in the home or with someone outside of the home, or exhibited other high-risk behaviors, or has trauma symptoms related to physical discipline or physical abuse. If the child has any one of these symptoms, that would make them eligible for AF-CBT as well, along with their caregiver. So we're just looking out of this whole list for one issue, one concern that someone is having about the caregiver or the child. So now I want to answer some of the more commonly asked questions about who can participate in AF-CBT. One question we often get is, what if the child is in foster care? That is perfectly fine. Frankly, if the child is in any out-of-home placement, that would still be eligible for AF-CBT. Children could be in foster care, kinship care, with resource caregivers, in out-of-home placements such as residential or group homes. Any of these children would be eligible for AF-CBT. What if it's not the offending caregiver? We're looking for a caregiver who can participate with the child, who has regular contact with the child, and is part of that child's environment. It may not be the offending caregiver in terms of a child physical abuse or discipline issue. It could be a foster parent, it could be a staff person at a residential setting, a resource parent. It could be an older sibling who's taking care of the child. What we're looking for is some person to participate in treatment with the child, be supportive of the child and the skills they're learning, and also learn similar skills to model in the home. What if the parent thinks it's the child who needs to be fixed? This is a question that we often get no matter what treatment we're doing. Parents who think that our job is to fix the child. One of the things we do in AF-CBT is we have a long engagement period. We spend our whole phase one really working to motivate and engage caregivers and children in treatment to help them see what the benefits of treatment could be for themselves and for their families. So we're not going to exclude parents who come in with that attitude. We're going to try and work with them to see if there's a way that they could be a partner in their child's treatment, to emphasize to them that they are the expert on their child and that they are an important person to their child. We also get the question, well, what if I already started working with the family? When you start our training, you're not going to then all of a sudden have all new families to try AF-CBT out. That's fine. It's perfectly acceptable to start AF-CBT with a family you've already been doing another evidence-based treatment with, or that you've been doing routine treatment with. We can work with you together, the consultant and you, to try and figure out where's the best starting point for you in the model. What does this family need? What skills have they already learned? What skills would help them to function even better as a family? And figure out how to help you start with AF-CBT.